I think I open by saying welcome to Auntie, don't I? The review that you've been doing, the absence review for 30 odd years now, which has really provided the major source of information about what's happening to sickness absence in the real world. And I think we're going to find it particularly valuable right now, that length of record as the team, the Frost Black team, starts to get to grips with what's really happening in the sickness sphere. That's an incredibly useful database. We're looking now, I mean, compared with when you started this survey in the 80s, there are a lot of changes and a much greater sophistication around our understanding of this area. And I think the most important one is this. When you started in the 80s with this, most people if you like, in social service, medical services, even government, thought that work was something to protect people from. And that has gone round completely. And now we recognize that work is part of the solution. And we've also begun to recognize, this is, we're being slightly slower on this, that we're over-medicalizing a lot of these issues. So there is a real swing happening in attitudes in this area. And I think there's still quite a long way to go, but there's been a lot of change and progress in recent years. I was actually incredibly lucky. Most of you will know I wrote my report on welfare to work and what the welfare system a little over 3 years ago now. Is that right? Is it 4 years ago now? Time flies. And 2007. And I was incredibly lucky that 3 months before I started to, and I knew nothing about the area when I started, which was also lucky, Waddell and Burton had come out with their piece of research that basically said work is good for you. If you're disabled, work is good for you. And so when I started to look at the what to do about welfare, you know, the big puzzle to me, having read everything flat, I didn't have any preconceptions. My attitudes hadn't been formed by something I'd read in the 70s or 80s or anything. I read everything that there was, and this was kind of came out in a major way as a major piece of evidence. And I said, well, why have we got a system, a state system, which is protecting people from the thing that's good for them? And so then we started to roll back or think about how to roll back the system. And clearly the most important thing, given that we've got nearly 6 million, 5.5 million people out of the labour market, forced out of the labour market or prevented from going back in by the structure of our benefit system, we've got to look at a way of at least pulling as many of those back in. And we've already started on that process. As you know, we started last month with starting to reevaluate 1.5 million people who've been on incapacity benefits, to start to try and flow them back into the economic life of this country. And we've done the surveys the pilots in Burnley and Aberdeen. The figures are public. And I think it's just shy of 30%, I think it's 29% of people were found in the new work capability assessment to be actually just fit for work, straight onto JSA. Now, that's probably not going to be the end point, because people appeal. We have a lot of appeals to tribunals. So we'll see where we get to at the end of that process. But nevertheless, that is a shocking number of people to be found just fit for work. And then another very large number of them were found fit for work with a little bit of help and support on the employment side of the employment and support allowance, and again that's a figure just shy of 40%. So with some work, some help, we could get all of those people back into the economic life of the country. The work programme starts, it depends on the area, but it's meant to be starting by June, early July, some cases, and some people are getting earlier than that. And as you all know in this room, that is really quite revolutionary in a number of ways. I think the most important way is that it doesn't talk about getting people a job. It talks about getting people into sustained work, and we've got incentive payments to encourage the providers, keep people in work out to 2 years and 4 months. And we're aiming to pay. Now it's a pretty rough and ready price differentiation we've got, because we didn't know what different types of people cost to get back into work yet. But we thought, well, let's just get some figures out, rough and ready. It's quite a complicated thing to do, but it meant that at the top end, the hardest people to help now, the providers can get nearly £14,000 for getting someone like that into work. So that's a huge investment. You've got to obviously pick the people where the investment's worthwhile to chase, but there's a huge potential investment going in to helping the people that we're trying to help back into the economic life of the country. And one of the most interesting things, you all know the figures, that a huge number of the people who have got ill health have it for mental health reasons. Mental health strength is 42-43%, and actually the figures are higher once you have been out of the workplace for a bit, because you get depressed. Figures are up in the 60s when you take that total. And one of the most interesting things is, what do we do about mental health? I think we're at very early days in that. I was fascinated when I had a meeting with Turning Point, one of the people that try and help in mental health, because when we really dug down what was there, this was a rather cheap telephone-based service of how to help people who were having workplace problems. And when you analysed it, much of the support they were giving were to people who had problems asserting themselves. So assertiveness training, which meant that when they went to work, they were put upon, they got stressed, they couldn't handle it, and they had to handle how to stand up for themselves as a key way of coping with that, and that actually was in practice a huge amount of their intervention. What's behind? There is a theory behind. It's taken me a long time to find it, actually. All these different bits coming together, and it wasn't until I was put onto this by the team at NICE, who say the theory behind this was invented by a man called Aaron Antonovsky in the 80s, mainly in the 80s. And what he described, he looked at it from the other end of the telescope. Instead of looking at why do people get ill, he looked at why do people stay healthy, what makes for good health. And what he said was, what he says is that we're all assailed by pressures every day. Getting here was a pain, and whatever it is, loss of a loved one. The difference is some people have a resilience to it and others don't and get ill. And the difference between being able to cope was a sense of coherence and understanding where you stood, why things were happening to you. And the other interesting thing, he said, you can't divide health between physical and mental. Regardless, if you did not have that sense of coherence and that resilience, you were going to get ill, and it could be mental, it could be physical, it probably could be both. So one of the things we need to do is build up that resilience and that sense of coherence for people. And that theory, which is gaining big support now in in areas of the medical profession, starts to push us into the way how we look after people and what we should be doing. It's an important underlying theory, and clearly it's behind what my department, DWP, is doing in a lot of ways. We need to support people before they hit crisis point, and we need to get to them before they come into the state system. And that is one of the findings of Waddell and Burton, is that early intervention is really important. And we've got quite a lot of evidence now that a lot of the problems that people have got, people in this survey, are not particularly medical. I mean, up to 90% of the problems can be solved by interventions, support, helping people back into the workplace because there's something going wrong in the workplace. And that's clearly one of the things that we're discovering with the Fit for Work pilots. That one of the most interesting things about those pilots is how few people have got a pure medical problem. And I think the message is coming through. I mean, I think this survey, one of the most interesting things in this survey is how many employers now are concentrating on the well-being of their employees. And as you said, Neil, 89% now have stress management policies. But what we're looking at, if we don't get this right, is that there's a kind of a shadow welfare system going on between employment and between the state welfare systems. And that is the occupational and sick pay period, which is a long period. It's a 28-week period in this shadow land. And the concern here is not the people with short-term absence, and that's a different issue. It's the bulk of the absence here. I think it was 50% of the days, a third of the time are people with long-term absence, which we now suspect or know is not particularly medical. Let me just talk for 1 minute on the short term and the finding year after year in the survey that a lot of people feel that they have a right to take sick days off regardless. Slightly fewer this year than last. And that's really a shared problem where we have to rebalance the attitude of people about their rights and their responsibilities. And I think that's a common problem both for employers and for the state. The period, but let me just come back again to the longer term issue. 28 weeks is a long time for not very much to happen, especially when we know that early intervention works. And that's the reason that I set up the review, David Frost and Dame Carol Black, to look at this whole area and to recommend how we can improve the situation. And the team has, the Black Frost team, which is a formidable team, have begun to find out that it's a very complicated situation. It's much more complicated actually than we thought it was. And it isn't a question of there being a linear journey down the 28-week period. You know, you get ill, have your first time off, and then you just wait around for 28 weeks. And people switch back and forth into the benefit system early or later. And it probably reflects the different types of employment contracts there are, and different kinds of incentives, and financial incentives working between the two systems. And one of the early things we've discovered is that it looks as if people from the smaller firms are arriving disproportionately, or a disproportionate number from the smaller firms are arriving on the state system early than from the larger firms. There's some very interesting questions about what employer provision actually is and how varied it is, and why is it that so few employers take out sickness insurance on behalf of their employees, and then why is it that some firms pay very, very generous occupational sick pay, some rely on statutory sick pay, which is much less. So we want to find out exactly how all these interactions affect behaviour and what's happening in the marketplace. And clearly we'll be coming to, already are coming to employers to find out and explore what's under that. Let me just touch on the footnote, which Neil was talking about. It was, when it was introduced, it was the first major change to the medical statement since the formation of the NHS, amazingly. So it's not surprising it takes a bit of time to bed in. And that's exactly what the survey says, that training is going to be very important, and that many GPs have not received adequate training yet to distinguish it sufficiently from the old sick note. And as Neil said, moving to an electronic version may actually be a bit of a catalyst for changing how it's used. We've completed, in partnership with the Royal College of General Practitioners, intensive training now, face-to-face, with about 3,000 GPs, and hopefully they start to transmit that knowledge to their colleagues more widely. And we're currently working on embedding that kind of approach with as we train medical students and indeed trainee GPs, just to embed it. And I think the most important thing that you can see from the surveys of GPs, not employers as here, is that they buy the central message now. The central message that work is part of the solution and that part of their job is to get people back into it is an absolutely vital first step to get this fit note to do what it should be doing. And it's a slow burn, as Neil said, but it's vital that we have got the medical industry on board with the approach, and now we start to train and get them to work efficiently and work with employers efficiently. I think it was interesting in the survey too that showing that those who invest in these processes are seeing rewards, and the difference, a factor of 5 in the number of sick days between the top group and the bottom group, 2 days to 10 days, is quite stunning in pointing up the benefits of active intervention. And if we can get this right, there's a big prize. 17 billion is a lot to win back, and in particular, obviously what I worry about, as well as the cost to employers, the cost to the state, as we have people flowing into these long-term benefits unnecessarily and burdening all of us in a very powerful way. Not only do we have to pay taxes to support people, we do not have the benefit of their economic input. So it's a double cost and drag to our economy at a time when we simply do not have enough money, and we all know the horrific costs of supporting older people is something that people of working age are just going to have to do, and we cannot afford to have more people than necessary out of the market who are of working age. One of the themes in all this, and the sickness team I know have clocked it, is the importance of the line manager in getting people back, and be very conscious that any system that we have must not lose that particular benefit. And interestingly, the Dutch system, for instance, one of the criticisms of it is that it loses the direct involvement of the line manager in the process. We found in the Fit for Work pilots that about where we've now helped 6,500 people back to work, that a lot of these interventions are intermediating between the employee and the line manager effectively to help them get back to work. Those are pretty encouraging results. We're running on, we announced the other day, we're running on 7 of those pilots, the most successful ones, to glean more and more information about how that works. So those are going to run on till the March in 2 years. This is a big issue. We'll get the report in the autumn. It's the missing link between employment and the state support system. I don't know what the team will recommend, but I can tell you that we will be looking at those recommendations, and to the extent that they make a serious attempt to help with this problem, we will be taking them very seriously and looking to pursue action to join the gap between our systems and full employment. So with that, I will draw to a close.
Thank you very much.